Well, good afternoon. I'm Gene Paranak, the host of MedTech Crossroads. We are here at the Med Health Summit at Ford Field, and I'm here with Dr. Philip Levy, who is the Associate Vice President for Translational Science at Wayne State University, an emergency medicine doctor too, if I understand. Are you still practicing?
Yeah, intermittently,
Intermittently.
but as we'll talk about in the next, 20, 30 minutes, a lot of my work has transitioned to population health outreach with mobile care delivery.
And with good basis and good exposure to inform that work. As you were the keynote today here at the Med Health Summit, you were talking on democratizing data for healthcare innovation and action, and we'll get a little bit into that. But before we do that, you were kind enough to be on MedTech Crossroads a couple of times
Yeah.
during the pandemic, and at the time it was all just like, what on earth is going on? You were there informing us, number one, about what was happening locally. There were a lot of actions taken. But then also we were all sort of learning together from you what was actually happening as best we could figure it out. Now we've got a little bit of hindsight looking back at those days. I know it's a passion of yours to not only look back at that, but to look forward
Right.
and also to then say, what are the things that we should not forget? What are the things that we should do? And in general, what does healthcare look like, which I think is now part of the position that you're in?
Yep. So, maybe to just jump in and say,
Yeah.
I certainly hope healthcare doesn't look like the past in the future, because I don't think anybody you would ask would say that healthcare was good before. Some
Yeah.
people get good care. A lot of people get great care. I'm not, maligning the care we deliver. It's how is that care accessed? How is that care equitably distributed and shared? And how does that care really address the big issues? Because we still have the same problems before the pandemic, during the pandemic, after the pandemic that we've seen for decades in terms of people dying too young from preventable illness or preventable complications of things like high blood pressure and diabetes and high cholesterol.
And this really just accentuates the fact that we now need to talk about these things. We've always needed to talk
Yeah.
about them, but this gives some momentum to the conversation.
Yeah, a lot of us kind of describe the pandemic as the great revealer, right? Because people, well, Detroit, as we discussed a couple of times on the show, and as everyone is aware, was an epicenter of COVID and poor COVID outcomes early on and carried forth, right? That led to the development of a racial disparities task force in our state, which no other state had in the beginning. Some have copied it since. But it really is the idea that we saw a manifestation, which was poor outcomes from COVID. The initial perspective is it must be COVID that's causing these poor outcomes, but the reality is it's the many years of neglect from a healthcare system on a population perspective that leads people to be more susceptible to things like COVID and have bad outcomes. So said another way, you have a lot of people in our community, Detroit, surrounding areas, who have risk factors like high blood pressure and diabetes and high cholesterol. And I hone in on those because those plus smoking and obesity probably cover about 80% of the chronic illness that we encounter in the world today, right? But the point is that if people don't get care for those things early on, they develop what we call subclinical organ damage. They develop things in their heart, in their brains, in their kidneys that in the beginning aren't really detrimental. They're worrisome but not detrimental. And then they flip at some point to become a clinical detriment, and that's where people get sick. And so you have a lot of the community living in this sort of subclinical area with untreated risk factors, and then you throw COVID on top of it, too much
The
for the
great
system to handle,
revealer.
and the great revealer,
great
and people
revealer
die
comes out.
from
Wow.
that. And so the lesson from COVID really is, yes, we need better shared data infrastructures to understand how to identify where a pandemic might be beginning, might be starting to manifest, and how we can address it. But we also need to better understand how we use information to prevent the substrate, the population, from being so susceptible to this
To it in the first place.
Yeah.
I love what you said there, and I don't think I've ever thought about it before in this way. That the population health, and I want you to define these terms really
Sure.
quick for us. The population health that we didn't understand at
Yeah.
some level drove actual real life personal health problems as this great revealer came through. But just for even just backing way up, can you just define personal health and population health so that if somebody's listening and they hear this term population health especially, they're going to go, what does it mean?
So we'll start with personal health because that's quite easy,
Yeah.
right? That's the individual and their risk and their needs and what, how they engage with the healthcare system and what they do about things, right? Whether they need medications or it's diet modification or lifestyle modification or what have you. population health can really be defined as just the health of a population. I know that sounds kind of stupid to the audience, and I'm not meaning it that way, but basically the key to population health is what do you define as the population? So you can consider the population as all black people living in Detroit. You can consider it as the entire state of Michigan. You can focus on hypertensives as a population. You can think of it that way. But when we think more broadly about population health, it's really the overall health of a community, an area, the people that live within it. And when you understand what affects population health, you understand it's more than personal health, right? It's not just what does that individual do, what do we do as a society that contributes to the risk, and how do we start to address it at a population level so that the person can get what they need.
So if I'm sitting there as an individual and I happen to have hypertension or something, and my local hospital knows about me, well, that's great because I can get care. But you're sort of saying there's this higher level where does the region know what its population is up against?
And what's contributing to that,
Yeah.
right? So if you think about, I use an example during the talk, right? Somebody who lives in the vicinity of the Marathon oil plant, right? The oil refinery in Southwest Detroit. And, that person may have high blood pressure, right? How much of that high blood pressure or what proportion of that high blood pressure and its control is attributable to living in an environment where there's a lot of pollution in the air and a lot of particulate matter and other things that come from refining oil at a grand scale. Well, you could focus as a physician or as a healthcare system on how do I get that person's blood pressure under control, but at a population level, you need to question what are we doing from a societal perspective that may or may not be contributing to this, and how do policies change to affect that? How do we take policy from a population lens and have it augment the personal care we're trying to deliver?
This almost gets into a political question, not a sided political question, but nevertheless, as we talk here about data in just a minute and how you use data to examine population level things, is there any worry that large entities may have things uncovered about them that, I'm not talking like healthcare systems, I'm talking like, oil refineries and other stuff like that, where all of a sudden they may not want that kind of information to come out. Is that something that we're going to have to deal with as we
I think
think
it's
about
a reality,
aggregate
right?
things?
I think it's a reality. I watched the show The Good Nurse. I don't know if the movie, right? It was on, and it was talking about this one nurse who was slowly poisoning people in hospitals by injecting insulin into bags. I'm sorry if anyone's going to watch it and I ruin the movie. But the point is that similar to that circumstance, the hospitals knew something was awry, and rather than deal with it, they tried to fire the guy. And he worked in 9 different hospitals before somebody finally said, stop the insanity, this guy's killing people, right? And so you think about it this way, we're always going to encounter this, right? Everybody, organizations, whatever, they're always looking at that CYA, right? How do I protect my liability? To hell with the people I'm impacting, right? Why did tobacco companies fight so hard to, show that smoking doesn't cause lung cancer when we clearly know it does, right? Because they don't want to be held liable or accountable, which, as we saw, they ultimately were, and it led to, a hefty price to be attached. So you have this juxtaposition between we want cheap gas, but at what expense does it come for the populations we care for?
And there's a benefit there to the individual, who says, well, I only care about my health, I don't really care about the population's health. You might learn something about your own health if 10 other people happen to be having the same problem in the same region.
Right. And, but it comes down to, should we allow a refinery to go in a dense population area in the city? There's plenty of land. Can we put it somewhere else, right? I don't know. I mean, there's convenience, waterways, and all of that type of stuff that goes into industrial decisions. But maybe we come up with a solution that can help mitigate the impact on the community where that's located. So if you take environmental exposure and particulate matter and what have you, maybe, Marathon should be putting HEPA filters in everyone's home that lives in the vicinity of their plant, right? How can they be part of the solution? Not and maybe not subordinating the business model they have because they still have a business to run, but understanding the implications of running that business on the community in which they're
and it's
located.
population health, and this whole thing we're going to talk about
Exactly.
data that gives you that kind of information to even be able to ask the questions.
Yeah.
We all do like to drive our cars, and it is important. Talk to us also really briefly about this whole concept of prevention versus treatment, because I know this is a big focus of yours, and maybe it comes as a shock that doctors shouldn't always be the ones doing all healthcare, which is like, as a doctor, it's like, what, really? Tell me more.
Yeah.
Prevention versus treatment.
So prevention versus treatment, right? So we can think of treatment as once you have an illness, you need care that may be acute and episodic. You got a sore throat, you go to urgent care, you're fine. Maybe, you injured your knee playing, football. We shouldn't be doing that at our age anyway, probably. But
I've given that up. Never played it, but I've given it up.
That's good. But you injure, you need to go to the ER and get checked out. That's episodic care. You may need to follow up with an orthopedist. You may need surgery. Blah blah blah. That's kind of not prevention, right? That's treatment. You may end up having a heart attack or a stroke and need a whole bunch of care. That's treatment. Prevention, on the other hand, is trying to understand the risk at an individual level and putting in place the pieces to prevent the consequences from that risk. That risk can be biological, meaning, all right, my cholesterol is a little bit high. If it stays high, that's going to lead to me having coronary artery disease, atherosclerosis, which will lead to a heart attack, right? That's, 20 years removed, right? But it's identifying that risk in the population and not making the ability to identify that risk, not getting it caught up in the bottleneck of healthcare delivery that we currently have, right? And so maybe to clarify some of this and make it a little bit more accessible to everybody, right now all of healthcare is one bucket. You go to your doctor, and it doesn't matter what you're going for. It could be a nurse practitioner, it could be a PA, it doesn't matter. You go to a healthcare provider to get care. That care could be screening for prevention services. That care could be treatment for chronic illness. That care could be episodic for back pain, whatever have you.
And if you happen to be in an ER, we're going to triage you right there for any of the above.
Which is why people love the ER nowadays, because nobody wants to sit in their doctor's office and wait 30 minutes to be seen and then have the doctor put their back towards you, not because they're mean people, but because they're limited time is pressing and they need to fill out the record to be able to submit for reimbursement for that encounter. They care about you, but they also run a business, right? And so if you force things that don't need that level of interaction into that interaction, you create a barrier for many people to access it. Said another way, my mom, ill, has a heart attack, needs to see a cardiologist. That's one thing. That's treatment. That's important. Me, I need to get my blood pressure checked and my blood work done every year. Do I need to go take half a day off from work and sit in a doctor's office, or can I do this somewhere else? Because I don't need that doctor to talk to me about my family. I like the conversation, but he's not my best friend. I don't really care about what's going on. I went to my doctor for my annual exam because I needed blood work, I needed my blood pressure checked, and I'm 51 and I needed a colonoscopy scheduled.
You could have done all these things without being in that room.
Without being in that room. And that's the model of care we're really talking about now. And that's a lesson that we've learned from the pandemic, going, back to the beginning of the conversation. Whatever it is, the idea that people can have alternative means of getting what they need, and it doesn't have to fit the model that has been healthcare for so long. We've talked forever about patient-centric care, right? But we've only paid lip service to it. The patient's at the center of a hospital system or a care system that is not patient-centric at all, right? I still have to go to my doctor's office to get something. I still have to make an appointment, wait however long to get in, right? When alternatively, there might be other pathways. I could go to a mobile program and get screened. I could go to CVS and get my blood pressure measured. You can think about different entry points to get the care delivered. And in a prevention mindset, the goal is to screen as many people as possible, not to restrict access. So why use an access restricting mechanism like a doctor's appointment versus open access to many different
Which if we're in the middle of an emergency, maybe makes sense. And you've got this whole team there ready to go. But what we're sort of saying is your customer experience as a consumer would actually be better if I wasn't faced up to this thing that is capable of dealing with an emergency.
Well, and here's the thing. When COVID hit, right, we saw the failure of that system. So hospitals were inundated with sick patients. Everybody still wanted to get their testing done for COVID because they didn't feel well, not deathly ill, but still people, who had a little sore throat, a little bit of fever, but were okay, didn't need to get hospitalized, going to the ER because that's what you do, right?
Yeah.
And your doctor's office is closed, so you can't go there. And the system wasn't geared for that type of mass screening. The system is geared to identify problems on people and get them to the next level of care for what it is. So the system fell apart. And that's where we started to see communities like Detroit, our efforts in the city, which we talked about, to initiate drive-through testing and programs. How do you get people the care or the prevention screening work, in this case, COVID screening, right? It's somewhat prevention, it's somewhat, identification and diagnosis. But how do you create a system for effective and efficient delivery of that care that is different than the current system because the current system doesn't work.
And some of that you start inventing on the ground while you're in the middle of this.
Exactly.
Yeah.
You know, I mean, the expression building the airplane while flying has
Yeah.
been, overused during the pandemic, rightfully so, perhaps. But the reality is nobody's ever done this before. So we had to think of systems to, intake people, get HIPAA compliant results delivered to them. But at the same point, the system worked really well. Anybody who wanted a COVID test after a little bit of time,
Yep,
unfortunately,
once you got it implemented.
could get a COVID test anywhere they want. The system was then morphed for vaccinations, right? It was the same model. If we went with the old way, the model for vaccination was make an appointment, see your doctor, get your vaccination. We know from flu vaccines, like having them readily available in CVS and everything, increased uptake. And then we started to learn, why don't we take the system that we use for mass screening of COVID with testing, use it for vaccinations? It worked quite well. You can't force everybody to get tested, right? But you can create the infrastructure to make access to that stuff barrier free.
Barrier free.
And if we think going forward from a prevention mindset, it's the same problem with high blood pressure screening, diabetes screening, cholesterol screening, kidney disease screening. All you need is a blood pressure cuff, a little bit of know-how from the person doing it, and the ability to draw blood, whether that blood comes from a venipuncture or in the future, finger sticks and blood cards and what have you. Create the infrastructure that makes all that readily accessible to people in at-risk communities. And that's how you're going to change the outcomes here. You're not going to change the outcomes by wishful thinking that if we only go back to the system as it was before, things would be great, because it didn't work before and it's not going to work in the future.
Because you're trying to address all sorts of different things there. Well, as we look back at COVID, give us just a word about what do you think are maybe the top 1, 2, or 3 lessons that we need to take forward? Because I want to get to data. I want to talk about data with you, but what are some of the things looking back that we most need to keep in mind about what we learned?
Perhaps most important is we need, and this leads into data, we need accessible information infrastructure to be able to address new problems when they crop up and not invent the infrastructure on the fly and catch up to the problem, right? So, an example is COVID prevalence, COVID vaccination data. The state collected all that information, and in the beginning, the state held on to it very tightly. And I don't know, some of that might have been political, some of that might, who knows, right? But at the end of the day, when you have innovators like the room full of people here, like the work that we're doing, needing that information to best implement a solution, it's got to be shared. And so how do you create the right infrastructure to do that in a way that doesn't threaten patient, security, of information, but at the same time can help inform solutions? So I think data infrastructure is woefully inadequate in this country, particularly for these grand scheme, these grand problems, and that needs to change. We need to have greater flexibility in delivery models and reimbursement for those models. Right now, a lot of what's been done in COVID, vaccines were free, monoclonal antibodies are free, COVID testing for a lot of communities is free. That's great, but the infrastructure needed to deliver that is not free. It costs. Right? When we first started doing our work, it was all volunteers. You know how long volunteerism lasts? Only so long, right? Because people have to get back to their lives.
Part of the solution here was that we took extraordinary measures to make this free, but that's not sustainable.
It's not sustainable. I mean, you can make the things free, the vaccines free, but the people still need to get paid, and the infrastructure still needs to exist, and that all costs money. So how do you create a reimbursement model going forward that allows flex up during these times, right? Allows flex up to respond to the needs of the circumstance. And I think finally, though not really finally, but third point is that the reason for the poor outcomes, like we discussed, was the severity of the infection, but mainly because it was superimposed on a population that wasn't healthy enough to start with. And so from a prevention lens, why wasn't it healthy enough? Because everybody's forced to get that prevention care in the same system, and it doesn't work for everybody. Simply put, right? How do we change it so that the system can work for everybody? It can be delivered barrier-free so that the community is healthier and ready next time when the next pandemic comes along.
Yeah, in other words, it really wasn't not our business how the health of that person over there was or the health of that person over there was in a population sense, because there was a ticking time bomb sitting there that we weren't aware of.
I just to say, I think to some level we've been aware of it, right? There are umpteen publications on how impoverished minority communities do worse. We know this, right? And it's time that we move, and we'll talk about this in a minute, right? From the idea of data for identification to data for action, right? It's not enough anymore to say, yes, this population does worse because they have poor food access. What are you doing to bring food access to that population? We already know the problem. We knew these problems before the pandemic, right? But I don't think there was maybe the will, the fortitude to challenge the
Not
system.
actionable at that point.
Exactly.
Yeah, that's interesting. Well, and this brings us to data,
Yep.
right? Because collecting this data, using this data in your talk, you were showing some really cool graphics of how, at least in the city of Detroit, you guys have been able to look and start to chart some things and be able to, oh, I want to know that particular area, that neighborhood, whatever, what's going on. This allows you to do cool things. But tell us about your vision for data.
So our vision for data, it started prior to the pandemic with this concept of trying to understand why people in Detroit die more frequently and younger from heart disease. It all traces back to the risk factors, especially high blood pressure. We started to conceptualize this concept of what is the pressure load on the population, right? How much does blood pressure impact the population, and how is that different in a neighborhood by neighborhood basis? We have a big problem all in the city of Detroit. We have a big issue with lifespan inequality in the city of Detroit. There are neighborhoods across the city where people are dying 5 to 15 years younger than the state average. It's not the entire city.
Just
It's
certain
pockets.
neighborhoods.
It's neighborhoods.
Pockets.
So how do we try to understand what's going on in those neighborhoods? What's the risk factors, right? Is it more older individuals? Is it being in proximity to an oil refinery? Is it being near the old incinerator, which thankfully is no longer in business, right? Whatever it might be, what's contributing to that, right? And then getting that information in the hands, not just of providers, and certainly not just in the hands of researchers so that they can write another paper that does nothing to change health outcomes.
Yeah.
How do you get it into the hands of innovators, of incubators, and into people who are in the intervention delivery arm so that you can actually close the loop?
Yeah,
Right?
people can actually take action on it in the short term.
Exactly, and it's hard because you have a lot of new innovations coming in terms of sort of understanding, community-based sensors and environmental exposures, and this survey and that survey. But at the end of the day, what you really want to know is how does that tie in to action and better outcomes? What do you do with this information, and what you did with this information, did it change anything?
Yeah.
And the only way you can do that is when you start to integrate availability of health outcome data. And it's well beyond, just prevalence data or high level data that comes from the state and is 3 years old by the time it gets into the hands of people, right? You need it to be readily actionable so that people can see it in, if not near real time, with minimal lag from its, acquisition, and then show trends and changes over time. So I think that's a lot of what, I was trying to describe here. And our program around Phoenix incorporates multiple different health sources of data to look at risk and outcomes, high blood pressure and myocardial infarction rates in a community, but also incorporates a multitude of social factors, historic redlining, pollution, smoking, exercise, income, those types of things, to really understand where you want to try to target for upstream impact. An example from a policy perspective, right, is taking information on density of fast food restaurants in a community.
Wow.
If you have a community that already has a higher than normal stroke or heart attack risk and abysmal blood pressure control, and a Church's Fried Chicken and a Burger King and a McDonald's on every corner, the next time somebody comes in with a permit request for a building, shouldn't that come into consideration?
Should that be something we think about?
Right? We should be thinking about the health and well-being of the communities holistically when we think about how to use data. And that's what I mean about having that information
Because if we're seeing
available.
that correlation there, and we
Yeah.
see that every time we've got this kind of a store demographic here, we're having these kinds of health problems. We're not saying, no, don't do it, but we're saying, hold on, we might want to limit this, because if we can see that kind of control over it, it would be good to know.
Yeah, and if you can then combine it in a way that passively allows benefit to be shown, right? Imagine the first city councilor who says, no, we rejected that, and look, over the next 6 months, we saw a decline in blood pressure
Wow,
at
yeah.
the population level and, fewer heart attacks. Not saying that's going to happen, right? Could, right? Especially if you find communities that are harder hit. One of the things we can do by combining data with Phoenix is we have data from ER visits, so we can look at people who go to the ER for asthma. As an example, we can look at self-reported asthma rates, and we can see communities that have the exact same self-reported asthma rate, but one has 5 times greater ER utilization than another. Why? What are we going to do about that?
Yeah.
Is it because they don't get the right medications, or is it because there are environmental factors or other socio-demographic factors in that neighborhood that are there but hidden? And let's get them to
You
the
got to
fore.
get them uncovered.
You got to uncover it so that people understand.
This brings me to the topic of sort of data not so much quality. I mean, quality matters, data quality matters, but also data consistency or format. And the thing in the back of my head and my day job, medical devices, right? And we talk about interoperability. And so I'm thinking of this as an interoperability
Yeah.
problem, if you will. And one of the things that you find is that, oh, I took this reading. Well, how that device or that, system takes that reading might be different from how a different one
Yep.
does that. When you think about population health data, certainly if you're within a healthcare system that from the top can mandate this is how we collect it, great. But as you go and you incorporate more and more and more to it, do you foresee or have you experienced problems where they collected data on that topic and they collected data on that topic, but they didn't do it in the same way?
Absolutely.
And how do you address that?
Absolutely. And I think this gets back to that initial issue of personal versus population health, right? On a personal level, if I want to understand, I don't know, your heart disease risk, your cardiovascular risk, whatever it might be that we're looking at with a new device, I want to be able to ascertain your information and integrate it with other data streams in a unified manner to understand the complementarity of that piece of information. At a population level, that's a little bit less important, right? Because what what the concept really is how do we understand risk in an area, then deploy resources to that area, addressing the mediators and moderators of that risk. And it may be that an individual person in that risk profile requires something else at a personal level, but this helps us know where to go. And so we don't need to perceive a barrier to that integration of data because the uniformity in my end is geospatial alignment, right? Meaning that what matters most is I see these outcomes in this area, and these are the factors that go into it. That's a little bit less of a data challenge other than attaching a geocode to where that information comes from. The other piece is temporality, right? At a given time, a given location, and then changes over time.
You're not trying to compare a particular blood pressure reading between that person and that person. You're trying to say, okay, now that all these factors have added up, this person is in this condition and so is this person. Oh, look, they live in the same place.
Yep, and then Now here's where it kind of comes together, right? To better feed into the population understanding that uniformity of the data acquisition piece is important, right? You know what I'm saying? Yep. And so I think it depends on, understanding intended use of the information and then making sure, as you said, that everybody's kind of looking at it from a similar lens and understanding what you're trying to do with that information.
Yep.
If all I care about from a practice level is that my patients are all wearing these sensors and I can understand at each patient level what's going on, that's one thing. If at a practice level I want to know the population of my patients, well, how well does that information integrate with my EHR so that I can understand it? If I want to incorporate that into Phoenix, right? How well does that information, as you were saying, align with other variables that are similar and being collected? And there have been a lot of efforts from Odyssey, you may have heard of that, groups that are trying to streamline data information and transformation so it all looks the same on the back end. And common data elements and common data languages are evolving. But, some of the problem here is that some of the biggest players, like the EHR vendors, are not so interested in population. They're interested in what they do and everybody else either
Which is still
adopt in their product.
personal, individual data
Exactly.
records.
Yep.
Yeah, it's kind of amazing. Well, Dr. Levy, this is so cool what you're doing. And I think it's so neat, the new position that you're in, Associate Vice President for Translational Sciences at Wayne State. You're in this position now to take all that you've done in your emergency medicine career with everything during the pandemic, and you're passionate, clearly, about making it implemented and to a worthy population, too, here in the city of Detroit, Wayne State University.
Yeah, I appreciate you saying that, Gene. And I think, to all the, innovators and entrepreneurs out there that are listening, it's not just about here, it's about scale, right? How do we use what we're doing in Detroit as the proof of concept and the proof of principle to expand nationwide? There are many cities, and not as many that are as racially segregated as Detroit are, but a lot of cities with similar issues of socio-demographic challenges, poverty, what have you. How do you take the lessons we've learned here and apply them more broadly? How do we get the payers involved? And that's the next step that we're really working on, is trying to get the payers on board with this idea, because it's great to get grants and it's great to get funding. And, we talked a little bit before, and I mentioned in there the success that we've had, which is fantastic. But at the end of the day, the sustainability only comes when this is the norm, not, a demonstration or the exception.
Everybody understands how it works.
Yeah.
Well, we hope that when you are doing this nationwide, you're going to come on again.
Of course.
And it's only going to be about 6 months, so we're looking forward to that day. Dr.
Yeah, I
Filippini,
appreciate it.
Thank you for being with us today.